going to like just start with some few Pharm principles, and then we just hit the road. Okay. I wanted to give you guys some antidote in case you don't know. Okay, some antidote. Very straightforward antidote, right? So if somebody take acetaminophen, you have to know what you give them when the antidote that you give them, and usually it's acetylcysteine. That's what we usually give them. So somebody will get is a Rice syndrome with a lot of taking a lot of Tylenol or anything like that. This is what you give them. So this is the antidote for that. Sometimes they bring this thing. You have to know individual antidote. So people who take benzos, okay, Valium and or other things. The antidote is promazine. Okay, this is very easy medication. You should know. Like when you see it in answer, this thing is a free question. It's like, oh, this is the bonus. But I'm just telling you, you have to remember them. Straightforward. We talk about digitalis all the time. I intentionally did not say anything about it. You have to know the antidotes. Okay, it's basically immune fab that they give you. Is a digoxin antibodies that will bind to them. So you have to know that too. So you can take a picture, but I mean, these are straightforward. There's nothing to talk about them. Simple antidotes. We talk about heparin. I think I mentioned it. Okay, which is the same as Lovenox. Okay, and nozaparin. Okay, it's the same thing. The antidote, you give them protamine sulfate, like 1 gram of it. And sometimes you see this in the question, they just want you to apply it. Okay, if a kid has a lead and he's being exposed, he eat lead chips, they will describe it eating lead chips, usually giving them EDTA or Sysima. Okay, so if you've seen it before, you see a question like that, I mean, these are the drugs you give it to them to bind to the lead. And of course, if they're on narcotic, I give you something and then your respiratory rate go down, just give them the naloxone. Okay, straightforward. And we saw warfarin, right? We know what to do. Just give vitamin K because it binds to vitamin K factors. The another name for vitamin K, if they usually they will give you vitamin K, but if they don't, is phytonine. Okay, so phytonine. Yeah, so that's another name for it. So these are antidotes, like major medications you should know just by heart, like you know what to do with them if the patient is getting into trouble. Then there's some therapeutic range that a couple of them, as I put them together, that have 10 to 20. Okay, and so if in case you're having problem remembering them, it's only a few of them. So like the TCAs, the aminophilins, okay, and the theophylline. You saw me. We talked about it last time. And the phenotime. Those are the ones that have like 10, 20 level, and they look the same. So okay, so those one. Lithium is different. So these are the one that has 10, 20, because those are the common medication they give you, the theophylline and phenotime. But the other one, the Digoxin, the other one, they have their own way, because they're very, very difficult. Then, like you said, this is basics. The best way to recognize the medication is you have either the first name or last name. I think the last name is much better, right? So we will do the suffixes. So you know them. I've said this before. The fields are usually erectile dysfunctions, Lindy fields. So these are medication for male impotency, basically. And you know the ACE inhibitors, they end with the prior. So every time you see ACE inhibitor, something with the pill at the end. And the dipping, which is very common, It's a calcium channel blocker. Some of them don't have the dipine, but most of them, like nifedipine, yeah. So this calcium channel blocker. The benzos, like we talk about, they have the palm and the lamb. Okay, there's a bunch of lamb palm, but this one have palm and they have lamb at the end. Okay, so this is the benzos, the sedative medication. Of course, you know this one, statin. This is for lipid. So that's how you can group it out. I know the last name. I know this is the medication. You forget about the first name, and then you can solve the question. You don't have to worry too much about it. And the law, we saw a bunch of them, right? They are beta blockers. So you probably already know them, but just a quick review. And the Cillin, you know, they are penicillin derivatives. These are antibiotics. And then the Pressors, you've seen them, omeprazole. These are the PPIs, right? So sometimes you see this VIR. This is antiviral medication. These are antiviral. So he's taking care of like HIV drugs, right? You see them, they write it VIR. These are all antiviral. And then we saw the plays, the ATA-plays. You see, they are the plays, the thrombolytic, the bad medication to the clot busters. And the fill-in, which we've already seen, trophylline. You see, trophylline is a bronchodilator. Every time you see that, you know, it's a broncho. Some of them have anticholinergic effect. And iron, like warfarin, you know, so anticoagulation. And then you can have the deans, like cementidines. These are antacids or H2 blockers, right? And then the zines, I don't know if you've seen it, antihistamines, you know, they are the one to prevent hives and other things, antihistamine. So this is the last name for your review, you know, and we'll get to Pharm quickly. Cyclines. Every time you see a cycline, you know it's an antibiotic. I don't care what it is, just first figure out that it's an antibiotic, then you put them in the class. This is also antibiotic, mycin, but they act different because they are dangerous. That's why we don't put them together. They are the aminoglycoside, like streptomycin for TB medication, you know, the aminoglycoside, because then they causes the same thing, hearing problem and the kidney issue and the liver problem, you know. So they are different. We put them in a different category, right? Then the Tillins, we saw them yesterday, TCA. We saw the TCA dance. He has anticholinergic effect. He has like multiple cardiac effects, and the D is dermatitis. So all the signs I talk about: D, dermatitis; A, anticholinergic; and neuro; and then the C, cardiac; and the E is all of them. So TCAs, they start with the Tillins. And then this one is a little bit, but I think you can still use them. Pram and the IME. Okay, this is the SSRI we saw yesterday. So this is my cheat sheet for those medications, to recognize them, at least to just like a baseline. Okay, this is where I am. Okay. I'm going to clean this. Let's see. So clean all this. Let's see. I have to go for it. Then you see, every time I keep on talking about sulfur drug, because, you know, if you look at the questions, they keep on asking. So you have to know which drugs are sulfur drug at your fingernails, your tips or whatever they call it. That when you see it, oh, this is sulfur drug, I know what is the bad one is going to kill them. So diuretics, we saw them, right? Hydrochlorothiazide and furosemide, we saw them. The loop diuretics, right? And the diabetic medication, the sulfonylurea, okay, graberide, right? They are one of them. We saw carbamazepine, right? I can't list all of them, phenotine. So there's a bunch of them. So these are the common ones that I want you to pay attention to, right? So these are the ones, in case you see them, sulfasalazine. Sometimes they will give you away, sulfasalazine. They give the name away, and you know that there's sulfur in it. So there's a bunch of them. These are the few ones. And then, of course, Bartram. Trimethyl is a long name, trimethylparin. I don't know if I can spell it, methylparin. Sulfur, methyl, I think it's so. That's all. Yeah, it has a long name, but it's a combined drug. So these are some of the common sulfur drug. When you see it, you should worry. Okay, you teach them about photosensitivity, right? That's what we talk about, sensitivity. But the most serious is the Stevens-Johnson. Okay, that's the most serious one. So if they see a rash on their chest, call me. Photosensitivity, wear long sleeve, hat, sunscreen, that's all. Don't expose yourself. But then they can crystallize, they can form stones. This is new thing I want you to pay attention, stones. So they can crystallize, so crystallization, and affect your kidney. So if you see a question, they say drink a lot of water, yeah, drink a lot of water for all sulfur drugs. Okay, so that's those are the information I want you to pay attention to, right? But what is the most serious one, right? Most of them also causes Stevens-Johnson syndrome, which I said it, and agranulocytosis. So all sulfur drugs causes agranulocytosis. So you see why I'm talking about it. There's three things you have to worry about: the kidney stones, crystallization, Stevens-Johnson, and agranulocytosis. And therefore, we have to worry about them, right? Like we saw in the question. So if they ask about agranulocytosis, you will see it. If they're talking about Stevens-Johnson, you see they will describe a rash on the chest. If they're asking about photosensitivity, that one is not dangerous, and kidney is not that dangerous. But those are the things I want you to pay attention. Sulfur drugs, these are the things that kill them. Okay, somebody raised their hand. You can ask a question.
Okay, please, sir. I'm trying to look at furosemide. It's also included amongst the sulfur drugs. So if we have a question that has anything on a granulocytosis, we should also pick furosemide, because I've never come across anything like that.
Every sulfur drug does that. So most of the things they will talk about, that one is mostly potassium and dehydration, but they don't focus on it. All of them are sulfur drugs. So you don't know where they will take you. Just know that it's a sulfur drug, because it's a true sulfur drug. Even hydrochlorothiazide is also a sulfur drug. All of them are sulfur drugs, right? We don't pay attention to them too much, because those are not where the examiners want you to pay attention to.
Okay.
In terms of because of the hypokalemia. But they are sulfur drug. But if they don't give you that and they put those information as a sulfur information, well, you got to pick it. It's called sulfur drug.
Okay, thank you so much.
Okay. Then grape juice and antacid, that's the way I call them. When I say grape juice, I think I think of antacid, because they are bad. So they affect the liver from metabolizing certain drugs. So grape juice is bad. When you see it, whenever they give it to you, there's never answer choice that is right about grape juice. So avoid them in calcium channel blockers because they affect the liver from metabolizing them. If you're taking amiodarone, don't take it, right? We saw a bunch of them. Statin, you shouldn't take it. It's also taken by the liver. So any medication that and antihistamines that is broken down by the liver, specifically these four, because of the specific enzyme, they should avoid it. Of course, like I said, antacid is not my friend. So it shouldn't be your friend either in your test. Every time you see antacid, just let it go because they're tricking you. So that's those basics. Okay. Now we can talk about drugs. I decided to I think repetition is always the best. You can't
Excuse
cram
me,
everything.
sir.
Yes, ma'am.
Oh God, you just went so fast. On the grape juice part, is it the calcium channel blocker? What are those medications you listed there?
Calcium channel blocker, amiodarone.
Okay, amiodarone and calcium channel. Those are the one you
And
cannot take
statins.
with
Statins.
and statin.
Yeah.
You
And
cannot take it with
antihistamines too.
okay, you cannot take it with beta block. You cannot take it with grape juice.
Yes, no.
They would decrease or increase the infective.
They basically, if they destroying the enzymes, then they will make them more toxic, right? The enzyme is supposed to metabolize it. So if they are affecting the enzyme, then those medication will build up and become toxic.
Okay. Thank you.
It's great. You don't have to like cramp everything, but if you know the thing is better. So we're going to do things we've already said it, but one word about them. This is a Pharm companion. So one word about those cardiac medication, okay? The diuretics, we saw them, right? We saw the diuretics, which are the furosemide, right? The loop diuretics. Loops, which were the what? The furosemide. We saw them. And his friend, I say you should watch him because sometimes they will give it to you because they know everybody know and furosemide, they will give it his friend, right? What did they do? The most important thing you need to worry about is hypokalemia. Hypokalemia, that is the most important thing. Okay, so the B-sharp information, hypokalemia. The blood pressure is going to be low, orthostatic. Okay, fine, doctor. Okay, I'm fine with it. Okay, they are sulfur drug. Okay, they're not going to go there. But like I said, if they go there, okay, they affect the kidney in the beginning. It's okay. It get better. Everybody is on laces, right? But the number one thing I want you to focus on is the one I've highlighted. This is the end. I'm not saying anything anymore. Orthostatic, sulfur, kidney, I don't care about it. Hypokalemia, and you got to be sharp. So you tell them to take some banana to help with that. If you get out of bed and you get dizzy, get out of bed slowly. So when you see a question, don't worry about it. The other way they will trick you is what? Muscle cramps. They won't tell you that it's hyperkalemia. This is what they will give you. Somebody is taking laces, he has muscle cramp. Well, guess what? They mean the patient has hypokalemia. So do something. That's your priority action right there. I'm done with that. Hydrochlorothiazide. So this is a guide, it's a companion. We saw them, right? It's friend, I want you to memorize it, okay? Because that's what, if they want to trick you, this is what they want to give you. Clotrimazole, okay? So that is also, they are all sulfur drug, okay? And this one also causes hyperglu, which I told you, the glucose goes up, the lipid goes up, uric acid goes up, and calcium goes up. That's why it's called hyperglu. So glucose goes up, lipid goes up, uric acid go up, and the calcium go up. I don't care about any of them. What I care about is hypokalemia. The same thing, muscle cramp. They can be orthostatic, fine. This is what you have to worry about. If they don't go there, you have to know the other one. Sometimes if they're not asking about hyperkalemia, somebody taking hydrocortisone with the glucose is very high, where it's normal, it's expected, I'm not, so they will, most of the time your test is priority. So I believe they want you to go there. They will give you those information in addition to the priority function. And so you ignore the glucose, you ignore the calcium, lipid, and I will pick the hypokalemia. And that's for this guy. Okay. And then their bodies, the case pairing, okay, they say, well, we're going to hold on to potassium. Why are you getting rid of them? It's a spironolactone because he has effect on aldosterone. They know, everybody know this, so they give you his friend, okay, the pyranol. The pelerenol. So you got to know one. No, don't know only one. Just two of them, at least two of each drug in each class, so that you can be good. All they're doing is sparing potassium. So they should avoid potassium. And then the way to see it is hyperkalemia on the EKG, and they'll get a PT wave. So they don't eat banana. And usually we use it in liver failure, cirrhosis, and help get rid of the fluid really good by spare your potassium. Unlike this guy, they get rid of the fluid and you lose your potassium. Yes, yeah, that's what I mean. What I wanted to say. So that's peak T wave. Avoid any banana. Okay. So those are the diuretics you should know. Okay, so that's the group, first group. Then we go to the ACE folks. Quickly, we saw them, right? The ACE inhibitors and the ARB, they are bodies. What did they do? Is from the ACE there. So the first A is angioedema, and the C, they cause cough, and the E, electrolyte, so hyperkalemia, and the I is teratogenic, so you have to avoid it in pregnancy because of agenesis. And the ARB do the same thing, except it doesn't cause cough, so no cough because of the renin-angiotensin, the way it acts. I don't want to go there, but if you look at it carefully, that's why. No cough, no angioedema. It's very smart. It attacks angiotensin too. So no angioedema. And so it's a, you can use it when a patient is complaining about cough, yeah, you give it to them. This one, the B sharp, there's two things. For ARB, what you need to worry about is hyperkalemia, okay? And teratogenic, basically avoiding pregnancy. For ACE, yeah, you have a couple of them. This is number one because it's airway. If they give you option, cough, yeah, and hyperkalemia. So those are the one. So basically everything about ACE is bad, okay? And the easy way is easy to remember them because it is spelled by ACE. So if I remember A, I mean, it's airway. Cough, yeah. E, electrolyte is going to be I. It's mostly potassium. And then avoid it in pregnancy. That's all. So, and that's how the question would be, like the most priority information, right? And then we saw Digoxin. This is like crash course for cardiac pharm. We saw Digoxin. I told you he has a narrow therapeutic index. And the best way to remember signs and symptoms is to start from your head and go down. Your head, they have a neural problem, right? Then your eye, they have optic problem. So you get a change, the green, yellow vision, right? Then you go to the mouth, GI problem, which is number one. Okay, that's your number one. Anytime nausea, vomiting, yeah, I'm calling. Then the C, you get into your heart, your cardiac, as you're going down, okay? And then they affect your kidney down. So from top down, that's the way I remember my kidney. Those are this problem you need to know about. But what you have to focus on is the GI symptoms. All the other ones, because I don't want to get there. I don't want to have a cardiac problem, kidney issue, or what is going to make this drug dangerous is you avoiding the GI symptoms. Of course, they can go there and then for the cardiac one, the way they ask it is the heart rate. That if you know the heart rate, you got to take it 1 full minute, the apical pulse, right? The apical pulse, very important. So 60 for older people, 70 for a toddler, okay, and 90 for young one, infant. So if it's less than that, we stop it. That's the way they ask the cardiac effect of that, because it causes heart block. But your question is mostly, how do you teach this patient to know that they're going to get toxicity from this medication, and therefore they should focus on the GI symptoms? Of course, you got to know all the symptoms so that if they complain about yellow, green, this thing, yeah, you got to let them come in. They shouldn't go and see the ophthalmologist, right? And they should avoid things that will affect the kidney, right? So you have to know certain things too that they can avoid, which we already talked about it, but since I said that, they should avoid what? Hypokalemic, right? Magnesium, and hypercalcemia, right? That's why so it doesn't mean they should increase their potassium. It doesn't mean they should increase their magnesium. It doesn't mean they should bring down their calcium. Keep them normal. Like I said last time, just keep them normal. So if they ask you a question, just keep it normal as much as possible, but don't let them go down. Don't let them go too high. That's all. And the other things they should avoid is like mostly ephedrine, anything that's like Sudafed and those things, because it can causes arrhythmia. It causes cardiac arrhythmia in addition to that. And anything that increases your potassium, cause it lower your potassium, hypokalemia, then they should avoid it. There's a question. Let me see if I can see it. Yeah, ephedrine, localized. Yes, everybody got it. Yeah, localized causes hypokalemia. Ephedrine causes hypertension. Okay, and then calcium channel blocker, because it increases your calcium, and that is the cardiac form, right? We talk about the antidote, right? Anti-dig fragment, right? We already seen it. If they give it to you, we already see this. So anti-dig fragment. Basically, that's the medication you use if they have toxicity of digoxin, basically. And so, right? And then we saw the calcium channel blocker, so CCB, which I told you, your last name is Dippins. Okay, I'm not going to list them. And there's a verapamil and the thiazide. They're a little bit weird, but most of the time it's Dippin. But just know the thiazide. I'll just write it so that you know. And verapamil, so you can see it. They have weird things, that's why I don't add it to. But most of the common calcium channel blockers are called Dippins. You don't need to memorize this. Guess what? They are calcium channel blocker. They block calcium on the vasculature. Therefore, the muscles cannot contract. Every muscle need contraction, right? So contraction, you need calcium. If there's no calcium, what is going to happen? It can contract. So no calcium, they can contract. If the vessel cannot contract, it becomes bigger. So it relaxes. So it can hold more blood. So the capacitance, I mean, I'm going someplace, I don't want to confuse you guys, but the capacitance of the vein get bigger, the artery get bigger, such that it can hold on to fluid. So you have blood pooling, okay, pooling of blood in the vessel, calcium channel blocker. We do not talk about it too much. That's why I'm spending time so that you can notice the signs and symptoms. If blood is just pooling in your vein and your artery, what do you think? You're going to flush. Your face is going to look all red, right? You can get headache. And the blood doesn't go to the heart, so you get orthostatic hypotension. That's why they have those side effects. And then if the blood is staying in your vein, what is the most common problem people get? You get edema. This is why when they give you a calcium channel blocker, you can see, you can figure out the side effect. Because blood is just pooling, they get flushed, they have headache, orthostatic, hypotension, and edema. Think about it. Which medication does the same thing? That's the nitrates. They are the same, nitrate. Nitrates do the same thing. Anything that dilate the vein. You can think of any medication that you know that is a vasodilator or venodilator, supposed to give you flushing skin, headache, orthostatic, hypotension, edema. So don't put it in the box for calcium channel blocker. Take it with you. If I'm dilating the vein and the artery, then every medication who does that is supposed to have the same symptoms. And that's why they should avoid nitrate. They should avoid anything that causes is a vasodilator as much as possible, because avoid vasodilators as much as possible, because then they will get the same symptoms. What is another clinical implication for this medication? Is very, very good. People who have Raynaud and Singh disease. And Raynaud is like people, they have vasospasm of the vessel, such that blood flow doesn't go into their hands. So their hand become blue. It turn blue, green, blue color, basically no blood flow when they get exposed to extreme cold or they get stressed. When you see this in who do you see, this is not a priority patient, even though their hands are blue. It's because they get exposed to cold, extreme cold and heat, or they get stressed and their vessels constrict completely, and no blood flow go to the leg, their extremities. So their hand get what? Blue. And therefore, we know medication that can dilate the vessel. I give them topical calcium channel blocker. They can put it in their hand and rub it in their hand, you open it, and blood flow easily. So that's the treatment, topical or nitrate. So if you see a question like that, it's just like, that's what they're trying to think, let you think, application question, Raynaud disease, yeah. So you use the calcium channel topical agent to open the vessel and let the blood flow. Okay. So this is, we're killing the cardiac Pharm right now. So, and then we talk about what? Some beta blockers, right? The beta blockers that we talk about, that they're going to act on either beta 1 beta blockers, either B1 or B2 receptors. Your lung has B2 receptors, okay, because you have 2 lungs. That's why, and you have 1 heart. So that's the way I remember it. B1 is common, but there's in most of there's other areas to that B2 receptors. So B1 mostly on your heart, okay? And so if somebody has hypertension and asthma, well, you got to be careful not to block them. So we talk about the Pharm, which are common beta blockers that are very selective. So they bind to mostly beta 1 receptors. They don't affect the heart and the lungs. And so those are the bisoprolol. Okay, that's why I call them Pharm. Bisoprolol, atenolol, and metoprolol. And they are very safe. The other ones, propranolol, you may see it, they are not. So these are not safe. Nadolol are not safe. Even labetalol are not safe. But you have to know that these ones are good. You can give it to somebody who have lung problem, asthma. This one you cannot give it to them. They basically blocking beta blockers. They are beta blockers. What do you think they would do? Side effect: decrease your heart rate, right? So they decrease your heart rate, hypotension, and bronchospasm, because they can bind to receptors in the lung. But you have to be careful which one they give you. If it's a balm one, you can take the bronchospasm out. If it's not one of the balm, yeah, then it can cause bronchospasm. So you got to be worried about them. And we all even finished with the nitrate. We talk about the nitrate, right? It's a venodilator and vasodilator. And then, so they are the nitroglyceride. Or you can say isosorbide. Sometimes they will give it to you, but that's another one that you should know. Isosorbide is a nitrate, or Miralol. This one is used like when the patient has like really bad CHF. We give it to them in IV form, and then that means this is usually IV. They can't take it anymore. What did I say about side effects? They pulling blood in the venous system. So they get flushing, right? They become hypotensive, right? Orthostatic. They get edema, right? They get headaches, which are a common side effect. What you have, none of them are important. The most important they will want you to know is teach them not to combine with anything that has nitrate in it. That's why they avoid the fields. Avoid the fields, the cylinder fields. No, you can use Viagra. Okay, you shouldn't take anything that do that. So those are the way they will give it to you, because the side effect is common side effect. It's not that too much important, and the most important is that. Of course, if they're getting it through IV, this is the most important. If they're getting it through IV, think about it. This thing can dilate you really, and if you're giving it through the vein, intravenously, then it's going to be dangerous more. It just dilated it worse. So there's certain numbers you have to memorize. Systolic blood pressure, if it's less than 90, you got to stop. If the systolic blood pressure drop more than 10, yes, then you also have to stop. Okay, if you drop 10 from where they were before, yeah, you got to stop. And so those are this thing that you have to pay attention to. Some people will give you a range 10 to 30. It's fine. Just know that it's dropping more than acceptable. By the time it drops 10 to 30 or an average of 20, you can take the average of 20. Their blood pressure is less than 20. Less than systolic is less than 90, because it's a strong medication. So you teach them all these things as you've been looking at them. And then we talk about a nitro patch, right? It's a patch. And you know, the teaching they can ask you. The teaching doesn't apply to just nitro. It applies to any patch, no matter what. You just have one patch at a time. When you take it, you wear gloves and you fold it, right? You dispose it so that no kid will see it. You don't shave, right? You don't shave. You rotate the side.
We cannot see.
I'm not typing.
Oh,
you want me to type? Okay, I'll type. Sorry, I was just like, I'm not typing. Sorry. So, what did I say? Let me go back to my thinking, okay, so one patch at a time. Okay, don't shave, right? Rotate side. Sometimes I say some of the things you just come in. So rotate side, right? Use gloves to dispose it. Fold it on yourself when you take it, right? So those are the things you can take shower with it. Shower is okay. You can take shower, okay. The patch stay on 12 to 14 hours. You shouldn't stay for 24 hours. Otherwise, you develop what we call I forget the word for it, but it become ineffective anymore. You want to give your body some time to recover from exposure to that medication for a long time. So that's why you give yourself a break, 12 to 14 hours. Okay, so that's what you do. One patch at a time, rotate and so those are the things they may probably put in the starter, but that's what you teach them. And then the bottle, which you have to tell them, because that's the bottle. You have to like know everything about the bottle. The bottle is really dark, black, pitch black, no light. I don't want any light near that thing. Okay, keep it in the same bottle. Okay, keep it in the same bottle. Okay, don't change it. Okay, let it be the same. Don't leave it in your car, because we want to avoid the sun. Don't leave it in the car. Okay, we want it to be avoid anything as much as possible. And the most important is we get a 6-month supply. Okay, so that you have 6 months. You have 6 in front of you. So before you finish, before you get to 6 months, you got to go for a refill. So you got to teach them this. And then lastly, if they have chest pain, well, take one. If 5 minutes it doesn't get better, take another one. Call. Okay, so you call before you take another one. Don't wait until you take in 3 times. 15 minutes, 5 minutes, it doesn't get better, call, take another one. And keep on taking at least 3 within 50 minutes, and then that time the EMS will show up. Okay, so cardiac Pharm. Then we talk about the Pressors, norepinephrine. We have dopamine. We saw them yesterday in psych, because these are medication. They are neurotransmitters. At the same time, they involve with your blood pressure and other stuff. That's why when you have serotonin syndrome, everything goes up. Things make sense in science. Why does somebody have serotonin syndrome? Usually everything, blood pressure, sweating, everything, because it's a sympathetic stimulation. Okay, so dopamine, norepinephrine, they are all derivatives from that. They are from the same group. So if you're on norepinephrine, your blood pressure goes up, stroke volume goes up, cardiac output goes up. So don't be surprised when they tachycardic, everything is going up. When they're on this medication, norepi, dopamine, epi is acceptable. The other one that you may get screwed up with is gangrene. Okay, there are toes who get black. Please, that's okay. I said it. Whoever said no, I said it's okay. I'm joking. Well, maybe, but I know it's okay. Black is okay, because what does they do? They are vasoconstrictors. They're constricting your blood flow from most to the less important areas to the most important. When patient on this medication, that means their heart is not doing anything. So we want to get more blood there. So we constricting to improve their blood pressure. So the toe suffer because it's the most distal aspect of it. So the toe become ischemic. So when they have black toe yeah, it will fall off. Usually we call it dry gangrene because it's not a true infection. So don't think the patient is infected. It's dry because it's ischemic. It's dry gangrene and it will fall off or it get better. So don't focus on it, focus on the patient. So if in case you see a question like that, I mean, it's the most important thing you have to know about this drug. It's okay. So vasoconstriction is tightening the vessel down to increase your blood pressure. Vasodilation, the word is vaso. Vaso is the vein and artery. Sometimes we use vaso for artery and veno, but I usually don't distinguish them. It's the same thing. And then dilation means you make them bigger. Constriction, you make it tighter. If I make your vein, your artery tighter, your blood pressure goes up. If I dilate it, your blood pressure goes down. So that's the difference. Okay, so cardiac Pharm is on the road. And then we saw my favorite one, Amiodarone, right? And I told you about my P clone. That P, so it's it's used for arrhythmia, basically, mostly if you have ACLS, that's the drug of choice that we use most of the time. So it's an anti-arrhythmia. That means against arrhythmia, anti. So that means your heart rate is going too fast or your heart is confused and it keep on pumping multiple times. So anti-arrhythmia. So I will slow you down. And so we can use it for AFib, you know, so usage, you can use it for AFib, you can use it for ACLS, somebody is going into ACLS, you can use it. So they can use it for, and most of the time, AFib, patients on it. And I told you about the P clone, that's the way I can remember the side effect. And the P is your number one, it's your B sharp movement. Okay, that's number one. And that is pulmonary fibrosis. They won't tell you that. They'll tell you the patient has dry cough for several months. That's your sign. You should say, no, we have a problem. What do you check? PFT. So that's the first thing you do, right? And the C, right, is a cardiac toxicity, right? So I'm not worried too much about it. And the L, it causes the liver function, the liver to go up. So LFT, so liver injury. So what do you check for liver? LFT. And the N, it has neural issue, confusion, okay? And the E, right, is endocrine. The endocrine, they can make you hypothyroid or hyperthyroid. So you check for TSH. And the E, and the last one, so we've done the D is dermatitis. They have rash. They get like green rash on their skin. Which one is the most important? Pulmonary fibrosis. When you see pulmonary fibrosis, that's your answer right there. You got to pick it. It's number one. Don't worry about the other ones. What do you check? They ask you those 3-letter words: PFTs, LFTs, and TSH. And that's all you need to know about amiodarone. Question. And then the last one on the cardiac, I guess we're not done yet. It's coming. Diuretic. This is also they increase contractility of the heart. So you should expect cardiac output to go up, heart rate goes up, stroke volume goes up, and then blood pressure also goes up. So if you know what the medication does, it's very easy to figure out. That's why you can memorize. Okay, you can't done if you memorize. I mean, especially pharmacology, Just know what it is for. Contractility. Know what it's used for. And then the key thing that causes the problem. There's a question. I got it. No, I don't know about nephrotoxicity. It's neurological confusion. On amiodarone, no. So then we talk about a few medication on the ACLS. I just want to review everything. So we saw adenosine. You have to know this. Adenosine is a medication used for SVT. So SVT is somebody who have tachycardia by its way, is supraventricular tachycardia. When they come in, this is your treatment, vagal maneuver, right? If they have no symptoms, so no symptoms, vagal maneuver, right? You do or cardiac massage, not bilateral. If it doesn't get better, you give them adenosine. Adenosine 6 milligrams. That's the first dose. And it's given, you have to know how it's given, IV push. What does that mean? This is fast. You just slam in there 1 to 2 seconds. And then you add 20 ml of sterile saline behind it. Just push it in. You tell the patient, ma'am, your heart is going to stop for a few seconds. You get better. We'll bring you back. That is the scariest time of, if you're a doctor or a nurse, of your life, that you just clear the patient within a few seconds, and then the heart reset and come back. So you got to tell them that. If the 6 milligram doesn't help, you give them 12 milligram. If 12 milligram doesn't help, that means you fail. Therefore, what do? You have SVT, you give them 6 milligram of adenosine, it doesn't help. They have no symptoms, so you give them, you do vagal maneuver, no help. Adenosine, no help. 6 milligram, 12 milligram, no help. That means you failed. Your only option is to cool down the heart, let the heart like relax. So synchronize cardioversion. And then you bring them back. Okay, so that's adenosine. What should you tell this patient? They don't like it. So you tell them it's a common side effect, so they shouldn't worry about it. It's flush because it dilates everything up. That's how they control the heart. It's a cool down. So they get a flush skin. And so they have a flush feeling, in their face. And don't worry about it. It's not the problem. If you see it, they will describe it in a scary form. No, that's okay. It's not a problem. There's a question. Turn on sync mode. Yeah, I like that. Somebody said turn on sync mode. You got to turn on the sync mode. Otherwise, you get into trouble. Okay. And then we saw atropine. Atropine, you know what it is, right? Atropine is against cholinergic, right? So atropine. Atropine basically is an antidote, okay, for if you have too much cholinergic effect. So it's when somebody is bradycardic, you give it to them, right? It's 0.5 milligram, that's all. If they are symptomatic, so if they are symptomatic, this is what you give them. If they have symptoms, I keep on saying symptomatic. What does that mean? They have hypotension, they confuse, they sweaty, with a heart rate of 60, no matter how high it is. I can have heart rate of 70, and I'm doing this, please give me atropine. Okay, you don't want me to cramp down. So don't look at the normal. Heart rate of 70 with hypotension, confusion, sweaty, they get transcutaneous pacer. Don't give them atropine. So if you have a symptoms, you get this transcutaneous pacer. No symptoms, you get atropine. And that's all I want to say. The other thing I want to say is, I told you, is anticholinergic. You guys know that. When I say that, you know what's anticholinergic. Or there's 3-4 places you have to look. When you see anticholinergic in your test, or you give somebody anticholinergic medication, 4 places, right? Look at their eyes, their mouth in terms of saliva, okay? Their GI tract and their kidney, right? You know, kidney function. You guys know what I mean. And maybe their skin, you know. Anticholinergic means everything goes down. So their eyes, you know, dilated, mouth dry, GI, well, constipation, urine, low urine output, and then they can sweat. Okay, so you should be by now, you should like, it should just be coming just like that. When you hear anticholinergic, you know what it is. Somebody have a question, though?
Yes, sir. You say with the atropine, if there's symptoms, no, you don't do if there's symptoms, you don't give them. If there's symptoms, you give them atropine. If no symptoms, you pace them.
No, the opposite.
Okay, see you one more time.
If they don't have symptoms, you give them atropine. If they
Okay,
have
no symptoms, atropine. If there's
yes,
symptoms, you pace them.
yes.
Okay, let me read it. Okay, thank you.
Mhm.
Excuse me, sir.
Yes, ma'am.
What did you say about the GI, kidney, and skin? Only know about the dry eyes, dry mouth, urinary retention, and
And constipation, that's GI.
yes, constipation, yes.
And they can sweat.
Mm-hmm.
Okay. So that's why they there.
Thank you.
The constipation is GI.
Mm-hmm.
Okay. So let's clean this one. And then you saw my boy starting, you know what it is. HMG CoA. What time is it? Oh, more than an hour, guys. HMG CoA reductase inhibitor. I told you these are the, how to remember it. That's the enzyme. And the H is basically liver injury. So you check the LFT. Check the LFT. The M is your B sharp moment. Okay. So this is bad. They have muscle pain, myopathy. So you should call the doctor. G, the glucose, is not important. I don't care about it. If they give me glucose 500, okay, fine. Okay. And the C is another B sharp moment. The muscle protein, that's CPK, creatine kinase, okay? Or I put a K there, will be elevated. If you see more than 5,000, yeah, they have developed rhabdomyolysis. Okay? So that's another bad stuff for this medication, right? And the A, you should avoid it in pregnancy. Right? And the R is the rhabdo, another B sharp. Okay, you got to stop it. You're destroying the kidney. So, and how does the rhabdo present? Urine is black or dark. Okay, so they have acute renal failure because the muscle breakdown and all the debris from the muscle protein form a clump and go into the kidney and block the kidney and destroy the kidney, and you get acute renal failure. Whenever you have renal failure, what is the most dangerous electrolyte you should worry about? Hyper K. So they have hyperkalemia. Therefore, we got to do something about it. That's why it's dangerous. And the I is the same as insulin, glucose. Okay. So There's 3 bad stuff about this medication: muscle pain, CPK, and rhabdo. If I were you, that's the one I pay attention to. They give me GI symptoms, glucose is high. I don't care about it. I care about CPK, that is high. I care about rhabdo, and I care about muscle pain. They take this medication at night. So they take it at night because you make cholesterol mostly at night. So that's it. And if there's they give you numbers, you already know I told you about 50, 100, 150, and 200. So you start with the alphabetically. There's 3. I'm not going to list them, but I want you to guys to yourself do it. So HDL, LDL, triglyceride. I guess I'm doing the same thing. And cholesterol. So that's the level you want it to be. You want this to be less. So this is greater than 50. Okay, that's good. This one, like less than 100. This one less than 150. And less than 200. And I told you, if they give you 300, somebody have cholesterol of 300, and you put them on the medication and it's 295, guess what? Just keep them on it. Don't say the medication is working. You just drop it by 5. It's working. Keep on going. Okay. And that's all. And then we saw the anticoagulation, right? We did the anticoagulation. So this is like a crash course on the cardio anticoagulation. We did a warfarin. The key thing is not in pregnancy. You can use it. It's not good for pregnancy. Okay, it's a vitamin K dependent factor. So it blocks like 2, 5, 7, 9, 10, and C and S. It's not important. Just say it's a vitamin K dependent factor. And what do you check? PT, INR. And I told you, you want to make the PT to be 16 to 25. 16 to 25. And the INR to be 2 to 3. If you're on prosthetic valve, so if you have a prosthetic valve, you want to keep it higher, a little bit higher than normal. Okay, 2.5 to 3.5. If they give you biologic, okay, biologic valve, or sometimes they use the word, it's not coming to me. It's a pig or some porcelain valve. Okay, porcelain, yeah, porcelain valve. That's the trap. This is not a mechanical valve. Okay, this is not mechanical valve. So they don't. You want to improve the anticoagulation, but just know that it's different. It's a different kind of valve compared. This one doesn't. It's not thrombogenic compared to that one. Okay, and they will not need anticoagulation for a long time. That's different. If I have a biologic valve, I don't need anticoagulation the rest of my life. If I have a mechanical valve, yes, I would need it the rest of my life. And then the most important thing I told you is don't change how much vitamin K you're taking. Just stay with the program. If you take 2 grams a day, take it 4 grams a day. Don't increase it, because if you increase it, then you bleed. I don't know what is the problem. And then you should avoid the 4 Gs. I'm not going to list them. You guys know the garlic, the ginseng, the ginger, the cocoa, all the G's. You should avoid them. They should avoid all of them. The key thing you have to know is this is bridged. They need heparin. They need heparin for coumadin to work well. So you cannot use warfarin alone. So in the beginning, you put them on warfarin plus heparin. And then by the 5th day, you get a PTT to where you want it to be. No, PT to like 25 or INR to where you want it to be. So you get an INR to like 2. So it takes like 5 days, sometimes 7 days to get there. Therefore, if I have a patient, think about it. I have a patient, I put them on heparin and coumadin because I want to bridge it. It's been 7 days and their PT is still, or their INR is 1. What do you guys think? What do you think? Its INR is 1. It's 7 days. This is not good. It's bad. Okay. This is the patient you have to see. Because it's been 7 days, you cannot get them to have therapeutic level. They're going to clot. We want their blood to be thin. That's why we put them on heparin and coumadin. 7 days, we still can't get it. INR is 1. They're going to form thrombosis. And they're going to get into trouble. We want to get them quickly. So this is the patient you want to figure out why they are not getting therapeutic. The reason why you put them on this is because you want their blood to be thin so that they don't clot. And in 7 days, you'll not be able to get them there, you are in trouble. So this patient, I will see them. Even though INR is normal, look at the full totality of the question. I'm trying to get this patient to get, I put them on a coumadin for a reason why. And it's been 7 days and then INR is still 1. I have to see this patient. It's a priority patient. Don't let that be a trap. It's different though when it's normal, but if you have given them all this and you still have 1, yeah, it's not good. And then we talk about precaution. You teach them your starter, okay, that they can ask you. Use clippers, not razor blade, okay? Toothbrush has to be Bristol, right? I can't spell, sorry guys. I'm trying to beat the time, but then I can't spell Bristol toothbrush. Yes, right? And then don't take NSAIDs with that. Your floor should be clean, no rags on the floor. If you get black tarries too, you need to call me. I have my number with you. You're on the speed dial. You just call the doctor, speed dial doctor, you know? You need to have a bracelet on your socks in case you fall down. Everybody know this patient is on coumadin. Is a teratogenic, so wear condom, okay, on condom. Or something barrier, diaphragm or something, you know, so that you don't get pregnant. And if you want to floss, make sure it's waxed. Okay, wax floss, I think it's okay because it's gentle. And those are the things you tell them, and that they put in the SATA form. It's just like something you already know. Okay. Okay. And then his friend is heparin. His friend is heparin. Heparin is nice. He said, I'll be nice. He said, pregnant lady, you can have it. His brother is lower molecular heparin. Lower molecular weight heparin, which is, you have to know this. Not apparent. It's the same as heparin, but it's lower molecular weight. It can be given sub-Q or IV drip. The sub-Q, you don't need to check lab, no lab. IV drip, you need to check PTT. And you want to get it to at least within normal level as much as possible. And usually less than 70 is good, right? So that's where we want to get them. So based on the normal level of PTT is usually between 25 and 35. That's how I remember, it's 25. I take the coumadin and the higher level of coumadin and I use it. I clean it that way. Is that, yeah. The way I remember the PTT is, I know the coumadin, the last number is 25. So, and I add 10. So 25 to 35. And so you multiply that by 1.5 and 2. So you get like 45 to 70. So that's the range of PTT. If it's greater than that, patient is bleeding. You got to check for bleeding stuff. If it's less than 45, patient is going to clot. The same thing like the heparin we talk about. The same precaution. The only difference is this. You have to know that because it's a B-sharp moment. Heparin induced thrombocytopenia. What it means is every time you give somebody heparin, you got to know this. The first 4 days is fine. Their platelets will go down. That's your body. The heparin and platelet, they are no buddies. But after that 4 days, the 5th day, if heparin platelet has dropped more than 50%, at least 50%, or less than 150,000, yes, they have heparin-induced thrombocytopenia. What does that mean? Normally, your heparin, your platelets, what does it do? Help you clot. I mean, basically, yeah. So, and that's what they do. Low level of the platelet means really you form a clot and other stuff. What this is going to happen is the antibodies that you're going to make destroy all the platelets and they form more clumps. So even low level of platelets, these people have low level of platelets. They form in clots and it's dangerous. So they are low level of platelets. It clots more than what it's supposed to do. So they have clotting issue. So for these people, even though you have low platelets, think about it. You think, oh, if I have low platelet, I'm going to bleed. It's different. In heparin-induced thrombocytopenia, low platelet, they form clot. So what you have to worry about is DVT, stroke, yeah, thrombosis, severe thrombosis. So to treat this patient, stop all heparin. Every heparin under the sun, all heparin, stop. Even some of the IV tubings, if they said there's heparin impregnated, stop it. Okay, and then put on something that doesn't have heparin on it. Guess what? Lower molecular heparin is also, you got to stop it, which is a trap. Okay, this one to stop. And then I told you, you give them the Zabans, those who have the last name of Zabans or Gatobans. Yeah, you see their last name. Okay, there's a question. Classic, okay. Yeah. So then you put them Zabans. Antidotes, we talk about it. You give them protamine, right? 1 gram of protamine, and then they're good. And that's the heparin for you. And then lastly, hopefully lastly, I think it keep on coming. I don't think it's antiplatelets. And I list them, I say adapt. I'm not going to list them anymore. I want you to pay attention to the P, which is the Plavix, which is it's a different, that's the trade name, but they want you to know the other name. Okay, the other name is Propitigo. So that's what they usually will probably give you Propitigo, right? It's Plavix. And then the A is aspirin. So those are the two. If you don't know at all, I will know about the antiplatelet. What is he doing? It's antiplatelet. It's against platelet. It's going to drop your platelet and make you bleed. So your precaution is the same thing. Don't take NSAID. All the things you're supposed to do for coumadin, you do the same thing. If you see they are bleeding, also all this, you have to avoid it. You have to shave, make sure you have clippers. Same precaution that you do. There's nothing new. It causes thrombocytopenia. So when you see platelet less than 1,000, yeah, be sharp right there for antiplatelet. So any patient who's taking aspirin and he taking NSAIDs, yeah, you got to say question that in the question. And lastly, thrombolytic, right? The thrombolytic, we talked about them, the plus. That's the Atropine. These are the bastards, they burst the clot. And so they causes more bleeding. And so I told you what they will let you probably pay attention to is contraindication, because that's what is going to be dangerous. Since they're causing too much issues, you have to know when not to give it. It's a good drug, but it's dangerous. So for clinical implication, know when not to give. Because even if you give it in the right situation, it still causes problem. So know when not to give. So when not to give is when somebody already had bleeding issue. So if they have surgery, recent surgery, like within 3 months, yes, no. They can do that. If their blood pressure is uncontrolled, this is like systolic in the 200 range, yes, you can have it. We don't want you to get it. Like if you have brain surgery or recent trauma, no, I don't want you to get this medication, otherwise we get into trouble. So there's a question at the place, yeah. Yes. So we don't want them to do that. And then there's an atrial venous malformation. That means the vein and the artery are malformed. So those one can bleed easily. So those are the 4, if you don't remember, 5 contraindication of these medications you shouldn't take it. Yes, over 12 hours can take it, yes. You mean like over 12 hours coming with the cardiac problem? The indication, it has to be within 12 hours. The stroke is like 3 to 4 hours, and heart attack. So stroke, somebody is asking about thrombolytic. So thrombolytic, if it's stroke, usually 3 to 4 hours. I don't know, they've increased it a little bit to 3.54, but in heart MI, I think it has to be within 12 hours. So we'll come back and maybe 2-3 minutes.